Dr. Muralidhar. Yeah. Clinico pathological correlation of corneal keloids in children.
Muralidhar Ramappa. A very good afternoon. It gives me distinct pleasure to present our work titled Clinico Pathological Correlation of a Pediatric Corneal Keloid. So, do not have any relevant financial disclosure. As we all know, corneal keloids are characterized by the progressive grayish white elevated. At times they are gelatinous, well circumscribed corneal lesion, have a glistening white surface. Sometimes it could be chalky white or a glistening white surface. The keloids have been known to cause by the aberrant corneal reparative process. One of the contributing factor could be, I'll come to this one. We've actually labeled as a primary, secondary, and congenital. These are very uncommon lesions of obscure etiology. Can also have a systemic, association. Some of the systemic association in a primary keloid. Primary keloid means without any antecedent insult, whereas a secondary keloid following it could be in a trauma, surgery, or an infection, they're developing a keloid. So all this Lovis syndrome, Rubinstein-Thieback, and also one of the Ehlers-Danlos type have a tendency to develop keloid even without any trauma or insult to the cornea. Meaning, pathologically the genes which drive this process can also have a downstream pathway aberrant healing mechanism. Our intent is to report a clinico-pathological correlation and to match them, the surgical outcome. Idea is, some of these cases tend to recur and need to identify what are those. This is a single surgeon institutional interventional case series. And here I'll be presenting about 22 children's. This 22 eyes of 18 patient. And we clinically classified, as I said, congenital, which is right from the birth, primary without any antecedent insult, secondary following a insult. And all primary keloids have an underlying syndrome, whereas acquired, we didn't find any syndromic association. And we carefully look at, they had a distinct histopathological pattern. So I'm matching here. This is a case of Rubinstein-Thieback congenital keloid. As a histology, we typed it as a type 2 healing pattern. Again, this particular case has a Lovis syndrome, which also subluxation, everything eventually child developed. Again, that histopath shows the type 2. This is, if you look at carefully, this is following a glaucoma surgery. This is chalky white. Unlike these are, these are a little more pinkish. It's completely white. There are no vascular element. We typed it as a type 1 keloid. Again, this is a mixed variant, no syndromic association. Similarly, here you can also see a fibrous pans. So why do we need to histologically categorize them to prognosticate? Those with a type 1 tend to have extremely poor prognosis. Those with a congenital tend to have a poorer prognosis. Histopath actually helps in precision-based, tailored surgical excision of this abnormal lesion and end up having an extremely good outcome. You can see 10-year follow-up following a lamellar surgery is almost as high as 86% without any recurrences. So I end my case here. Thank you for your kind attention.
Yeah, nice compilation of all the cases. So, can you clinically differentiate between a keloid and corneal opacities?
Yes, madam. Keloid, as I said, there are a raised, elevated, glistening lesion, and they extend beyond the actual site of insight. Unlike an hypertrophic scar, regular scar, it confined to the margins. So it goes well beyond the boundaries of insult. So the same with the dermatology literature.
Yeah.
And other thing is the histopath. Histopath is a key. What we found is an aberrant epithelium, hyalinized reactivated keratocytes. I believe these are abnormal keratocytes. For any insult, they have an exuberant response. So sometimes we don't know what drives that exuberant response. It could be genetic, some of the genetic association, because we've seen consistently. In certain cases, it's still obscure. But at least, if we can clinically categorize type 1, 2, 3, we know, we can, which are the cases. Congenital needs definitely full thickness, where even endothelium was absent. Whereas the primary, secondary, we can just do a Desmet's bearing, deep anterior lamellar keratoplasty. That will ensure Okay,
Have you
recurrence period.
seen recurrence? That is what I was asking. Have you seen recurrences
Yes,
in any
madam.
of your cases?
Yes, one case initially I did a superficial keratectomy with a mitomycin. Within a year it became so aggressive, at least 3 times bigger than the original lesion.
Yeah.
Then I went for a DALK.
Okay. Thank you. Thank you so much.
Thank you, madam. Thank you.
One question, Muralidhar. Yeah, no, like the acquired variety, do they have an association with the skin keloids?
No, sir. All of them have had received BCG. I did examine very carefully the BCG scar. I didn't see any keloid tendency, also in a family. And also, historically, if you look at malnutrition, tuberculosis seems to be one of the risk factor for a keloid formation. And also, of course, racial, black race tend to have a higher keloid tendency than us.
But you have mentioned intrauterine injury.
Yes, sir. That is we do not know, sir. It's speculative. It could be, let's say rubella, but we could not find, when you run the titers.
Rubella we blame for
Yes, sir. Yes. Every time, you get everything positive.